In principle, we have two classes of compounds that we are currently using. Number one are the PD-1 antibodies, and there we have nivolumab, we have pembrolizumab in development, and the other one are PD-L1 antibodies, which are working on the same axis. And there we have the compounds of atezolizumab, we have durvalumab, and we have avelumab currently in clinical development. So I think these are the 5 most important compounds in lung cancer. Having said this, one of the strategies to improve efficacy of immunotherapy is the combination of different immune therapeutic strategies. And therefore, besides the PD-1 and PD-L1 antibodies, we also do have other compounds which are working on the CTLA-4 axis, and these are ipilimumab and tremelimumab, which are also currently in clinical development, predominantly in combination with one of the PD-1 or PD-L1 antibodies. One of the beauties of this new treatment is really the good tolerability of these compounds. The tolerability is much better than the tolerability of chemotherapy. So overall, if I would have a patient who would not be fit for chemotherapy in the pretreated setting, I would check whether he would be a suitable candidate for immunotherapy. There are some contraindications. So all patients with autoimmune diseases might suffer from immune-related side effects. These would not be candidates for immunotherapy. So these are really the main strategies to screen the patients whether they are of risk for some of these new immune-related adverse events. But on the other side, looking on the patient profile, it seems that across all histologies, these agents seem to work. There may be one exception, and these are the patients with oncogenic alterations. These are patients with EGF receptor mutations or ALK translocations. In this group of patients, we are not so sure that immune therapeutic compounds alone are the best treatment. So in this group of patients, we would go for a specific targeted therapy instead of offering them immunotherapies. We have learned that by the use of immunotherapy, we are not necessarily improving response, but we are achieving much more long response data. So we're seeing now 2-year survival rates. We are even seeing 3-year survival rates in patients with metastatic non-small cell lung cancer. And there are a couple of questions that we do have for chemotherapy. Number one would be the question, what is the best place to use immunotherapy? In first line, directly after first line, as a maintenance approach in the pretreated setting? The second question would be, how long should we give the patient these treatments? Currently, we are providing them with the treatment until disease progression, but we do not know whether this is really necessary. And the third question is, what do we do when this patient is progressing after immunotherapy? Is it possible to add something to the immune blockade to increase the efficacy of these compounds? What's the mechanism behind relapse after immunotherapy? And these are the very important questions that we do have for the future.